Hi everyone, so my name's Andrea Brimson. I'm one of the MSK physios based at Basingstoke Hospital. So today I'm going to talk about my research that I recently did on outcome measures, how I implemented the outcome measure, and where we are now with the data from the outcome measure. But I hope the word outcome measure doesn't make you all want to go into a post-lunch coma. I hope I'll make it slightly interesting for you all. So about 18 months ago now, I was lucky enough to gain some funding from NIHR Wessex to look into a research project of my choice. It was really invaluable. It gave me a day a week for 6 months to come out of the clinical setting and just dedicate my time into looking at research. And I chose outcome measures because, while information on utilisation and waiting lists and DNAs is really important, so is the quality of the care that we provide to our patients, and we can prove the quality of the care that we provide through outcome measures. So the title of my project was to investigate the most efficacious patient-reported outcome measure, and then digital use of this within MSK, so it's a scoping review. So I have 3 different objectives in this. When you start looking into outcome measures, it's a massive, massive amount of information out there. So I had to really kind of define what I wanted to do. I used the term efficacious because I wanted the outcome measure to be valid, reliable, time efficient, holistic, covering lots of different areas for the patient, not just pain, function. We needed to cover how their conditions affected their whole life. What are others doing locally and nationwide? What outcome measure are they using and how are they implementing it? And now we have gone digital with our note taking. We need an outcome measure that is also digital. But what are the barriers and opportunities to using an electronic outcome measure? So there were 2 phases to the project. Phase 1 has split it into the actual literature review of the outcome measure. Staff stakeholder groups, this is key for me. Staff who are going to be using this outcome measure day in, day out, and need to know what they want, what they need, what they think is going to work for them to help with the compliance of using this outcome measure. An audit of the current outcome measure, so the audit of the previous outcome measure that we were using was the PSFS, Patient-Specific Functional Scale. An audit of that showed that 16% of us are using it on the initial assessment, only 1% were using it on discharge. It wasn't working for us, and why was that? So I needed to look into that. I had to have close communication continually with the IT and business intelligence teams to make sure that my ideas were going to be feasible and that we were going to be able to use what we wanted to use electronically. So from the literature review, the best outcome measure, so the most efficacious outcome measure really through months and months of training through the research, was the MSK-HQ. So it's an outcome measure that has 14 domains on it. It doesn't just look at pain and function, it looks at sleep, well-being, fatigue, self-efficacy. It's a score, you end up getting a score out of 56. The higher the score, the better their MSK health status. And an increase of 5.5 on the scale is a significant improvement. And it's a patient-reported outcome measure. So it's a true reflection of how the patient feels that they've progressed, not the therapist just doing a score and thinking how they think they've progressed. It's a true reflection of how the patient feels they've progressed. It's valid for all MSK conditions, so inflammatory conditions, persistent pain conditions, which is a lot of what we see in MSK. The results from the staff focus groups, these are my key stakeholders. Some of the comments that they made were, it needs to be function-based rather than just focusing on pain alone. We want one measure. Previously, sometimes we've been using different measures for different conditions, but one measure for everything. Let's just make it simple. It needs to be meaningful and goal-specific for the patient, otherwise they just won't complete it. The main barrier to using outcome measures is time. Like staff, they know how important it is, but I'm just too busy. I don't have time to complete them. The data collected, it needs to be used. There's no point in us collecting all this data if it's not going to be used and it's not going to be fed back to staff. So I took all those comments on board when I was thinking of how we're going to implement it. Phase 2 then was looking at the barriers and opportunities to using the outcome measures electronically. Once I'd found the outcome measure, I then kind of sampled with a few patients some interviews about what they thought of it. Did they think that they would complete it? Did it look user friendly? And how they felt that it would show. Do they think it would be a good enough way to show their progress with treatment? Liaising with other MSK providers in the area was literally just emails, phone calls, Teams conversations with other providers who are really helpful and willing to participate, because they said we'd like to share your results if we can at the end of it. So the results from the scoping review on barriers and opportunities to using electronic outcome measure, there's loads and loads of opportunities. There's a few barriers. So some of them are that it improves patient-clinician communication. So if we can see how a patient, the areas that the patient is struggling with before they come in for their assessment, then it helps to streamline our assessment. It empowers the patients through self-management. They can see the areas themselves that they struggle with. It can reduce medical visits if we can track patients' progress electronically. If we can see that they've massively improved, it could just be a phone conversation rather than the patient having to come into the hospital to see us. It's much more time efficient. If the patients can do it at home, it just saves us loads of time within the consultation to spend that valuable time with the patient assessing and treating them. If the data is stored electronically, other healthcare professionals can access it, so it improves clinical workflows. We can ensure sufficient benchmarking of MSK physio services against others if we're all using similar outcome measure. It helps to highlight training needs, because on the MSK HQ that we are now sending out to patients electronically, they will write down the area of the body that they are seeing the physio for. So if we see massive improvements with ankles, but maybe not so much with shoulders, we may know where we need to kind of concentrate our training needs. The disadvantages are patient survey fatigue. We all know that ourselves. Oh God, it's another survey I need to complete. I'm not going to bother doing this. And the IT infrastructure, that's the biggest barrier. That needs to be in place within the hospital and for the patients. That needs to be readily available. So what the patient, they were telling us that when they looked at it, they thought it was good. They would be happy to spend 10 to 15 minutes completing the MSK HQ. Research shows that it only actually takes 2 minutes, so patients were happy to fill it out. It's a measure of my health, so it's important to me. It's not just a survey on an Amazon delivery. The electronic version would be better. It meant that the physio could spend more time with me. But the score should be used as part of the assessment, and maybe some signs in the waiting room would help to lift my spirits. It was a patient I spoke to. She said that when she first came, she was really anxious. She didn't know what we did, and she didn't know whether we were going to make a difference to her life. But actually, she said if we could see some data in the waiting rooms, that would kind of help calm her and make her realise we can make a difference to people's lives. But some did say if there was no score, I think if there was no change in score, I would feel a bit disillusioned. So For the other MSK providers, most of them were using the MSK HQ. Most of them were emailing them out, linking them to EPR. Some used a doctor-doctor, which is the same as our patient hub. So looking at this, I knew that it was kind of feasible to be able to use this outcome measure electronically if others around us were doing it. So where are we now? So from the research, we've now implemented the MSK HQ onto Patient Hub. So the patient now, before they come for their initial assessment, they are sent the MSK HQ electronically via Patient Hub. They complete it before they come to see us, and then when they're discharged, they complete it again. And then that data is then fed back to us, and it's us now analysing that data. What needs to happen continually is the staff training to make sure that staff remind the patients to complete it, but also for those patients who haven't got the IT infrastructure, we will log into Patient Hub and complete it with them. So the staff need to be aware of it and know how to use it. And the exciting thing is that we can link it to demographic data, so age, gender, ethnicity. So we can link the MSK health status to demographic data, which helps us to see if there's any MSK health inequalities, which is a big push with the Hampshire and Isle of Wight ICB at the moment, looking at health inequalities. So lots of exciting things we can now do with the data that's coming through. But some of the data that I have that's come through so far, now there's 10,703 surveys that have been sent. So there's huge amounts of data coming through, which is a bit daunting. But 41% of people are completing it, 59% aren't. But that's better than the previous, and the second slide, the second pie chart shows that's 41% of the 41% who are completing it, 41% are doing it on discharge, 59% on initial, and that is better than the compliance rate with the old outcome measure. Of those patients who have completed the outcome measure on their initial assessment and on discharge, from February to June, 76% of our patients are showing improvement, and 55% of those is a significant improvement. And June to September, really similar figures. So we're making some good improvements on our patients, which is fabulous to see. This is just another slide that we can show against some of the demographic data that we're getting. We can see that between the ages of 60 to 70, that's the highest compliance. Rather than the younger age groups, they're leading busy lives. They haven't got time to complete another survey, but maybe between the ages of 60 to 70, they have got a little bit more time. But they might also just be because that's the biggest age range of patients that we see. And the average score people are showing is between 5.5 and 10. They're increasing that much on the MSK HQ. And it's lovely to see that the 90 to 100 is showing the most, but that was only because it was one patient. But that one patient improved by 30 points on the MSK HQ, which is amazing. So my learning really is that I would encourage everyone to apply for the funding through NIHR, to give you that time out of our busy clinical diaries to dedicate to looking at the research. Be patient. It's taken 18 months to get the MSK HQ onto Patient Hub. It didn't happen overnight, but I didn't give up sending those emails. It's now continual data collection. Excel is not my strength, but Mark Pulley, our business manager, has been fantastic in helping me pull that data. The compliance is it's 41% are completing it, 59% aren't. We need to look into why the 59% aren't, so still work on that. And that continual feedback to staff, you're doing a great job. 77% of our patients are making really good improvements with what you're doing. Keep going. And that's it, I think. Yeah.
Good afternoon, everyone. Yeah. So basically, I'm from India, so I'm an Indian, so that is what, like from India to England. So before starting with the presentation, I just wanted to know how many of us are internationally recruited or internationally who came here for work or studies or anything? Oh, all right. So I think you might relate a bit more about what I'm talking. At some point of time, you would have gone through the same thing and you have come out of it. So, and the others who are not internationally recruited, so they might, it might be a bit eye-opening for them how we feel when we come from different country, what we expect, and what we expect from you guys and things like that. So that would be like that. So come to the presentation. So I'm Asmath Sulaiman. I work as a hand therapist here with hand therapy team in MSK. I work in Basingstoke Hospital. So just covering a little bit of my career, how I started. I am just in start of my career right now, but I just wanted to tell you how I came, like career-wise. So I started with a Bachelor's of Occupational Therapy, which is like I did in India. So I come from south part of India, which is Chennai. So yeah, I live in a city. So we have a good, very big institute, which is called as SRM. Science and Technology Institute, so it's an university. So I did my bachelor's there, which is for 4 years and 6 months of internship. And after bachelor's, I immediately did my master's, and I was specialized in hand therapy there. So which is for again 2 years. So after that, immediately I started with HCPC registration because it's a mandatory thing for all the AHPs to be here, to work here. So it took a couple of months for my HCPC to come back, and meantime I started with my interviews. I gave my interview for maybe 3 or 4 trusts, so which included mental health and orthopedic and many other things. So, but I'm more into physical in ortho, so I just wanted to be here. So I don't know anything about this HHFD place or like Hampshire, nothing. So I don't have any relatives, cousins or family here. So I just okay, HHFD, I'm just going with that because it's ortho. That's what I know before coming here. So I started with Band 5 rotational occupational therapist in Winchester Hospital. Yeah, Anna is here. So I started with elective ortho, and then I've got a new opportunity which is hand therapy. So yeah, currently I'm a hand therapist. So that's a small gist about my career pathway, and I don't know what holds next. So that's it was not like it was easy for me to tell like in few seconds this is my journey, but it was not really easy for me to achieve this. So because I come from Islamic background, so I'm a born Muslim. So like they are strict Orthodox Muslim family with including me, we are four siblings. So it was not easy to pursue studies for us. So according to mostly Indian society and also Islamic society, females are not allowed to get education. So even if you get education, you have to get married by 19-20 maximum and have kids and settle down at home. So that is how it goes. But when you want to break it, when you want to achieve something different, it is quite challenging to convince yourself, convince your family, your society, everyone. So there were many challenges, and I have to just bet for studies to work and everything. So it was not really easy. So that's my family. As you can see, I'm completely different from my family. So that's my dad, white shirt, and the one with the yellow hijab is my mom. And they are my 2 sisters. I'm the eldest of the family, and we are 4. And yeah, as you can see, like, you know, I'm completely different from every one of them. So initially it was really difficult for my dad and mom to accept it. Like, why is she like that? So is something wrong with her? So that is how it started. And even I was not sure what's happening to me. I was explaining them, I want something different. So now they are a bit convinced, they're proud of what I'm doing today. So I'm happy about that. So that's a small thing about my family. They are, yeah, of course, they are everything. They are my weakness, my strength, sometimes my worry, everything. So choice. So I just wanted to tell you the process which I have gone through might be different for, like, many people might not know what is the process of me being here. So it started with an interview, as I said, and it's an online interview, so which was just a Zoom call, and then maybe on the same day or the next day, I've just got a mail that you have been selected for that, and within no time, maybe less than 1 week, HR team, they contacted me. It was really quick, and I have to thank my HR team now. So because they have been updating me each and everything of the process which is happening, because my dad thought it's a scam. So you're just sitting here talking to someone, you say that you have got a job in England. Are you serious? Like, of course I did. Like, he didn't trust me until I boarded my flight. So then he was like, please, if you have any problem after reaching there, just give me a call. He thought again, like, until I reach here on the video call when I showed the hospital, that is when he trusted me. So my HR team was quite, like, they were like, they updated me each and everything. So this is what is your application status, and we are working on your sponsorship, so everything. So that was really helpful. So once I got my sponsorship, they sponsored my visa, my flight tickets and everything. And then that is like, oh, okay, they're giving you flight tickets. Are they going to sell you or what? So you have to be, like, be really careful. And then, so they gave me a bit of orientation, and I have a couple of presentations before coming here. So they told me about the culture differences, food that you can expect, and the weather, and the way people use words and things like that. Like, the communication is not so easy. Sarcasm, they use this, so you have to, you don't take it personal. That is how they talk. So everything, each and everything, they updated even before me coming here. So once I got my sponsorship, my visa, and then my flight tickets, I have to board my flight in maybe a week or so. It was really quick, and yeah, I came here. I landed in England. So again, after landing here, this is the first time I'm seeing Britishers. So just imagine, like, white skin, like, oh, how are they going to talk? Like, how am I going to answer them? Am I going to understand? So everything, so many mixed emotions. But I just, like, this is my first flight, so I haven't been in flight, so this is my first time. So when I came here, I don't know how to go out. Like, I just came out and someone is standing with my name board, like, it's me. He didn't even talk to me, even a word. Just dragged my luggage, dragged me, just sit inside. He just took me. He just took me here to, like, accommodation. I was here in accommodation for 3 months, which was 3 months free accommodation, and they told you can just take your time, settle down, know about place and people, things like that. Once you are settled, you can move out of the accommodation. I thought, oh, yeah, it is much better, isn't it, to be in a safe hand. So, like, when I reached the accommodation, I was, like, welcomed by HR team. So they gave me orientation about each and everything. So how to cross the road, where to walk, where not to walk, where are the shops, how to do the billing, and things like that. Small things, but I still follow the same things till now, because it's all new to me. For them, it might be small things, but it was really new to me. So about the currency and about the food and where are the grocery shops near you, where you can get Indian food, things like that, basic things. They gave me orientation about all those things. So I am, like, really thankful for that. So many of my colleagues and my classmates who did my masters and bachelors along with me, they're also working here in UK, but not everyone got this opportunity or, like, this much pampering of what I got. So in that way, I'm a bit lucky. So once done with the orientation, applied for my health for work, my GP registration, everything. They helped me with everything. So, and my BRP collection, so they did my employment checks and everything, and it took a really long time for me to do all the employment checks. And it was the day for my first day at work, so I was really excited for that. like this is my first job officially after my graduating. So I'm that in different country, different people with NHS, because it has been always a kind of how to put, maybe a dream to work in a proper systematic medical setup, to learn how to work basically. So I was really keen to learn things. So yeah, I was. So when I tell about my new job, so it had its positives and negatives. Because I was new to the place, new to the system, everything was a bit challenging for me. I know what is NHS, just the full form of NHS, that's it. I don't know anything more about it. So I don't know how the process works, from where the patient comes, what's the pathway, nothing. I was not aware of anything. So every day is a learning for me. So each and everything I have to ask colleagues, I have to learn from them. So in that way, my colleagues were really supportive and teaching me, like, small things. So, and I started with, like, as an occupational therapist, it was a bit challenging for me, because we work with people, like, close in contact with their house, the environmental modifications, the equipments that they need, and I don't know how their house look like, and I don't know how does their bathroom look like, what they do need. So nothing I know, because in India we have only just like when you say bathroom, just it's a wet room, that's it. So here you have different names, different terminologies, everything means different thing. So while taking assessments and everything, it was really hard for me. So my colleagues helped me again in teaching everything. So, as I said, it was a kind of positive and negative. I was not really happy. So, I thought, because I don't know these terminologies, I was left behind kind of, because at one point I thought, I think I don't know much. I am not fit to take assessments. Let me just hold on for a few weeks, let me learn and then do assessments. So that is what I felt, and my confidence was really low. Because I am really confident, like in my profession, I thought, I can do everything, but after coming here, no, you can't. It's really hard, you can't. So it was a kind of mixed emotions, and I was not so really happy with the work which I was doing, because I thought, like, you're not doing really good. So, and I think there are few people whom I met, also who had a prejudgmental thing in their head that she is from different nation or a country, she might not know. So they came to a conclusion that she won't know, she's not allowed to do things alone. So whereas other people who started along with me had an opportunities, whereas I didn't have. So I thought I don't want to term it in any way, but I felt a little bit odd, and I felt I was not given enough opportunities in that way to prove myself. So at one point it went to a state where I was not happy with the workplace and I want to change the work or just go back to India. So I was like that. So but I can't go back to India because I have fought for this place. So I was just trying to figure out how to solve things for myself. And at that point of time, I don't know whom to talk with and who is going to support me or who is going to voice over for me. So I started looking for new jobs, and that is when I got a new opportunity that there's a new opening in the same trust with a different work. So I applied for that, and I was like, oh, this is a new opportunity. It came when you're in a lowest form of your life. So you have to take it, just grab it and make it happen. So I made it happen. So that's my team. That's my hand therapy team. We don't have a proper picture that I got. So, and sorry, I just wanted to thank few people who helped me out when I was really low. My colleagues, my friends, and yeah, as I said, I don't have any friends here, so my colleagues are my friends. So my colleagues and my patients' feedback. So when I got feedbacks from my patient that like you are this, you are that, that just boosted me up a little bit. So and then because I was really low, I started doing some things that I like actually. Like I started hobbies, art, like drawing, painting, things like that. So yeah, so there are a few things that helped me to just come out of these things. So yeah, I've got a new opportunity, and I started my job with hand therapy in January of this month. So I have been in Winchester for maybe 3 or 4 months, and I started with hand therapy in January. So it's an amazing and lovely team. So where each and everyone helped me in just everything. Like because I'm new to their team, so they just help me with understanding things, understanding the process. Not like I can ask them all stupid and random questions. They will be like happy to explain me and to just stand by me. And then they were really, I think in everything they were really confident, and they were trusting me more than what I do. So that is when I felt like not like being in a good team, being with proper teammates will bring a best out of you. So I realized that. So it has been six months now, more than 6 months. So I've got like awards and certificates and gifts from my patients and letters and like everything. So I thought like all my positives which were there before, like you can't communicate, you can't do this, you can't do that. So everything, all the negatives just changed into positives with like, maybe like me as a person has changed a lot. Like I'm more confident, I'm more like happy with what I'm doing today. So I'm happy for that. So it all changed because I like after changing, what I thought is like, okay, you have gone through a phase of life where you have tried changing yourself. There are many people who are also going through the same thing, or should not happen with this. It should not happen like the people who are coming in future. So I thought I'll speak up and just tell what I have gone through, so they can make some changes, and things might be easy for the people who are coming in future. So I started talking to people. That is how Venus came. She used to come to me, and she'd be like, "Oh, are you okay? Are you okay?" She used to come and ask me. Then I was like, "I'm okay now, but I was not okay a few months back. So do you want me to talk about that?" So that is when I started talking, and Ashley, she's here. So our speaker guardian, so I spoke to her as well. So I would encourage like everyone like who are internationally recruited, who are going through the same, maybe who are working here, who have been here. If you're going through the same thing, like anything negative, or if you feel like something can be changed, speak up. There are people who are there to listen here. So once I started talking every week or every month, they have been updating me of what's really happening with your issue. Come on, we are doing that. We are trying to change this. So they are making changes. That made me confident a little bit. Okay, you can start talking. There are people to listen. So if you're a bit skeptical about talking to like health authorities, you feel, oh, I can't go talk to them or something like that. Just talk to your friends and colleagues. Just share with them. And if you are that friend and colleague, support them. Talk to your managers, support them, and stand by their side. That really means a lot. When you stand for your friend, that is more enough. Their stress just comes down a lot. So, and yeah, there are a few things that our trust is taking over. So that is Speak Up Guardian and Ambassador program. So this is for AHP, like not all the international recruiters. So recruit international staff who came from different countries. So we actually have been allotted ambassador, so where we can just keep them as a friend, just talk to them like a friend or something. So if you have any questions, you can just go for them. So that is how I have been allotted with a nurse. She works in theatre, so her name is Augusta. Now she is a best friend of mine. So I have like she have been like, they introduced me to her through a formal mail. So we had a meeting in theatre, so she welcomed me with a really tight hug. So she said, "That's fine, come on, let's make it." So in everything, so she stayed with me. And even today when I said I'm going to talk like this, can I post your picture, to ask her permission, she's like, "I feel so happy, I feel like a proud mother." So that's the words that she used that meant a lot. So she stayed with me all this while. So I think coming from different country without any background or any friends, people like these, like, small connections which the trust take efforts to make, these connections means a lot. So yeah, thank you so much for this opportunity.
Asmath sharing her journey, and actually when I listened to her journey, it was, I will say that it was actually quite disheartening for me to hear, but also it was very interesting because, I'll come to your question in a minute, but I also found it very interesting because I wasn't internationally educated, well, recruited, because I actually came over in this country, but yet when you actually share with me your journey, it was very interesting because back home, only rich people have a bath, all right? So when I came over here, when you have to learn about the state, all this sort of thing, I was like, oh my God. So there's a lot of things people don't really realize. But one thing I really want to say is the fact that I'm very grateful that we still got you, because I know that you were going to leave the trust after a couple of months, few months actually, and the fact that you persevere, you stayed, and actually you found a team that you belong, and you've got some friends, and I think give it up to Asmath. Any questions or any comments?
Hi, good afternoon, and congratulations to all the winners. And my name is Del, and I'm the Practice Development Lead in Main Operating Theatres here in Basingstoke. Although my heart is into nursing, I am privileged to have to be working with a lot of allied health professionals in Main Theatres. My matron is an ODP, the theater coordinator is an ODP, and they're here, Claire and Debbie. We also are supporting a lot of trainee ODPs, and they're all here, Steve, Israel, and Joseph. So it's an honor and a privilege to be working amongst them and to be with you all. And the conclusion of this presentation will also be given by Sarah Forshaw, another PDL in Winchester. She's an ODP. Okay. My presentation for today, first part is Pause for Gauze. When I asked Sarah about presenting this, I said to her, should I really present this because it's for quality and safety? Because I said I might scare the audience because it is quite scary as I go along the presentation. Let me just define what Pause for Gauze is. It is the point when the scrub team need time and concentration to count carefully, and this is according to the national guidelines, which will be discussed by Sarah later. So this is the point when you do surgical count to make sure everything is accounted for. What you use at the beginning of the operation should all be accounted for at the end. So that is the Pause for Gauze. But how did Pause for Gauze, how did we come to really implement Pause for Gauze in main operating theaters? Sorry, technology. Okay. The background behind us really giving emphasis to Pause for Gauze in main theaters was because of an incident of retention of swab, meaning to say swab was retained inside the operative area and the operation was finished. To give you an idea of the gauze or the swabs that we have used in theaters, I've got samples here. We've got this kind. We've got this. And yes, this one can also be retained, this size. So those are the kind of gauze that we use. Bear in mind also that the items that we also use that could also be retained are surgical instruments and surgical needles. So this also covers this Pause for Gauze. So the incident happened, retained swab. So of course when it happened, they did policy reviews, we had meetings, so we would it wouldn't happen again. However, in the same month that the first incident happened, it happened again. A retained swab, of course, is you unintentionally retain a swab following an invasive procedure such as surgery. And it is a never event by NHS England, meaning to say this event is wholly preventable because of the existence of strong systemic protective barriers at the national level. But it does happen, and it's still happening. When the second incident of retained swab happened, there were extended discussions, investigations, policy reviews, and meetings until we had an email saying, we really should put an emphasis on pause for cause. And this is under the national guideline, which is not SIPS. This is actually the poster in all theaters. We made this during the meetings, which is pause for gauze. And as you can see at the bottom, with the emoji of keep silent, no noise whilst count is in progress, please. So these are the posters that are in existence in all 7 theaters upstairs. The elements of the pause for gauze that is also posted in theaters, you've got these elements. But what I'm trying to emphasize is the pause for gauze is when the surgical team must concentrate on counting, there's no noise, the scrub practitioner must call out when it's time to count so that there are minimal or there are no interruptions while the count is ongoing so that everybody can concentrate. When we implemented the pause for gauze, I have observed, although I don't have a statistical data to support it, the staff were encouraged and empowered to speak up and challenge those who do not want to cooperate when we do a pause for gauze. When you do a count, they don't necessarily say, pause for gauze, please. There's always other ways of saying this, like, can we all concentrate because I'm starting to count? Does the surgeon have everything? Do you have everything you need because I'm starting my count? Can we all please be quiet because I'm starting my count? I know of a timid scrub nurse who is shy, speaks quietly, but I have witnessed when it comes to surgical counting in theaters, her voice is really loud and clear, and she would speak up and say, it's time for my count, can you all please be quiet? So that's a positive impact of the pause for gauze. Of course, when you want to introduce change into a team, into an institution, into a company, to the NHS, there are varied responses. One, of course, are those who say, I don't care, I'll just go with the flow. The other response would be being receptive, and the other is, of course, being resistant. So if you imagine a surgical team, you've got the anesthetic team dealing with the airway, you've got the circulating team opening sterile stuff for the surgical team. So the surgical team, you have the surgeons, you have the scrub practitioner, which I was for many, many years before I became the practice development lead. So who do you think among those teams are most resistant to change?
The surgery.
I heard answers, but this is being recorded, so I want to come out safe. So I'll leave you all. I will all leave you to ponder, but I also have the answer on my mind. If you want to know, just ask me later. Okay, for the pause for gauze as well, we have to be reminded that we have a duty of candor. This means to act in an open and transparent way with people receiving care or treatment from them. So those patients who have come back because they had retained swab, I can actually tell you that there was a maternity patient, retained swab in the vagina, came back, and they had to remove that. So there were investigations as well, and they are being updated. They also are given the results and the things that we need to change so that it won't happen again. And before I forget, why is it important not to retain swabs or any foreign body, after the operation? The results could be, the non-serious results could be distress, further surgery, prolonged hospital stay, extended time of work. But of course, the most serious is infection, and if the infection becomes systemic, it will lead to death. So that's why it's a never event. It should never happen again, and we have to follow strongly guidelines so these things will never happen again. I will leave you now Sarah to discuss the national guideline that includes the pause for gauze.
So we just talked about the linking with NatSIPs to do with the pause for gauze. So the pause for gauze happened because of a particular incident, and we needed to implement that for obviously patient safety. The NatSIPs relates to actually safety guidelines for any invasive procedure. So whilst we're talking about something that's specific to theatres, it actually applies to anybody in any situation where there's an invasive procedure. So that could be putting chest drains in A&E, it can be in endoscopy, it doesn't have to be in theatre. But the implementation of the guidelines as well are to apply it so that, so that the patient stays safe. So regardless of the environment, if you are walking out into a waiting area to call your patients, it's about making sure that you've got the right patient and that you're going to give them the right treatment. So we have the advantage that most of our patients come to theatres, they'll have a name band on. We have something to check them against. That doesn't always happen in other environments. So the NatSIPs actually applies throughout the NHS. It isn't just for us within theatre. So over all major and minor procedures, so the clinics and if any of you have watched some of the human factors training on Green Brain, there's a small video there about within an outpatients and about the mistake of names and the treatment and the information that's given to the patients. So that implementation of have I got the right patient for the right procedure at the right time should be implemented across all situations. So the way we have it within theatres is through the team brief, and we have very specific points where we will carry that out. So at the sign-in, the time-out, checking against the implants going into the patient, the reconciliation of the items, so that's the part we were talking about, checking that those swabs and instruments and needles and everything is accounted for. We recently had a case where that this process actually worked, so that there was a swab missing and they were in the process of closing the patient, and everything stopped and that process was followed until the swab was found, so that when the patient left theatre they were safe. So it was evidence that actually those processes actually do work. We audit these, Martha, we audit these to ensure that it's happening, because biggest part that we found, so it's a process that we're putting in place, and if any of you have done human factors training, it's about creating that environment to make it difficult to do the wrong thing, but that's only one part of it, is that process. So we can follow those steps, but as Del was saying, sometimes it's still happening, and we're having to look at why that still happens. And the qualitative data coming from that is actually around creating psychological safety and creating the right culture within the environment so that people feel comfortable and able to speak up. So that's where the empowerment comes. And that actually, very honestly, is still our biggest challenge. It's definitely improved. It's one of those things that we're still working on. But you can put all of the processes in place that if somebody doesn't feel empowered and comfortable and confident to actually implement them, then actually it still doesn't happen. So we are in a privileged position, I think, within theatres where we have so many processes to try to keep it safe, but that's because it can be one of the most dangerous environments, because the patient generally is not awake, not able to speak up for themselves, and we're very much patient advocates. I would encourage any of you, if you haven't done human factors training, to do the full day training. We recently had a very senior member of staff attend human factors training, and it was actually observed when returning to theatres on how their interaction was different and how that supported the team. So if any of you haven't done it, definitely go and do it. But it's the reason that we're talking about it here is it relates to patient safety, and it's something that you can all implement in your own areas of care.
there's my title. So today I'm talking to you about my journey from a support worker to the MRI operational lead, which is a brand new role within our department. So this is my leadership growth. So I started in the trust back in 2015 as a radiology assistant. Well, I started as a healthcare assistant in outpatients first, and then I moved to MRI as a radiology assistant. I don't very often talk about banding. It doesn't define who I am, but today it does kind of give a bit of a story to why I'm talking to you today. So when I moved